We'll continue to deal with developmental defects of craniofacial structures, and we'll be taking and covering only 3 important topics for today. Cleidocranial dysplasia is the first which we'll be looking after. It is also called as cleidocranial dysostosis, Marie-Santon disease, craniocleidodysostosis. Looking at the etiology, there are two major factors, that is hereditary and genetic. Hereditary appears as a true dominant Mendelian characteristics, and when it is coming to the genetic inheritance, there is a defect in the CBFA gene 1 chromosome producing cleidocranial dysostosis. Let us look forward into the presenting clinical features. The disease affects the men and the women with equal frequency. The classic sites commonly involved would be the skull, clavicle and dentition. First major feature is a shoulder meeting in the midline. There may be complete absence of the clavicle and patients have unusual mobility. They can bring their shoulders forward until they meet in the midline as shown in this figure. Next is the head. Head is a brachycephalic with anterior posterior dimension being increased, and also skull will show fontanelles which will remain open or they take time to close, and open skull suture with multiple Womerian bones are present. Next is the lacrimal and zygomatic bone will be underdeveloped. The sagittal suture is characteristically sunken, giving the skull a flat top appearance. And lastly, the nasal bridge is depressed with the broad base. Let us look into the oral manifestations. There will be micrognathia. Maxilla and paranasal sinuses are underdeveloped, resulting in the maxillary micrognathia, which will produce mandibular prognathism clinically. Prolonged retention of primary dentition and delayed eruption of the permanent teeth will be noted. Numerous unerupted teeth are found, which are most prevalent in the mandibular, premolar and incisor area. And also there is a presence of high arched palate as shown in this clinical picture. There is also presence of hypoplasia of the enamel and also pitting present. Radiographic features. Skull will reveal certain features, whereas when we do a chest examination, it will reveal malformation and absence of the clavicles. When it comes to the oral manifestations in the radiography, prolonged retention of primary dentition, presence of supernumerary teeth, flattened mandibular angle, pointed coronoid process, roots of the teeth are often somewhat short and thinner as shown. And moving to the skull, there will be open sutures present, presence of Womerian bones, widened cranium, delayed ossification of the fontanelles, and frontal and occipital bossing is more prominent and a classic feature of a cleidocranial dysplasia in a radiography. How do we diagnose these conditions? Meeting shoulder in the midline is a typical feature of cleidocranial dysostosis. Supernumerary teeth, open sutures and absence of the clavicle are present in the cleidocranial dysostosis radiographically, giving us 1-point diagnosis of this disease. How do we manage these conditions? There is no treatment required for these anomalies. Patient can lie or live in the normal life. Whereas it comes to dental care, supernumerary teeth, they should be extracted, prosthetic replacement to be carried out if it is must, and unerupted teeth should be extruded orthodontically to give the aesthetic replacement for the subject. Next defect is the craniofacial dysostosis. It is also called as Crouzon's disease or syndrome. It is inherited as autosomal dominant trait. In other cases, affected individuals have no family history of the disease, and the disorder is characterized by distinctive malformations of the skull and the facial region, and this is one of the classic cases presented. Let us look forward into the clinical features presented by these subjects. It is evident at the birth or during infancy. The fibrous joints between the certain bones of skull close prematurely, and they will produce craniosynostosis. Craniosynostosis in infants with the Crouzon syndrome, there will be fibrous joint between certain bones. Hence the name craniosynostosis. Other two features are proptosis and strabismus. Proptosis, facial abnormalities typically include unusual bulging or protrusion of the eyeballs due to the shallow eye cavities as shown in the figure. Strabismus is outward deviation of one of the eyes, widely spaced ocular hypertelorism, and this will lead to blindness. Next cranial malformation presenting is the premature closure of the sutures resulting in brachycephaly, scaphocephaly, which will be having a boat-shaped head, which is also shown in the figure, and or sometimes a trigonocephaly, a triangular shaped head will be present. In extreme cases, they will demonstrate what is called as clover leaf skull or Klebat-Skaddle deformity. There will also be presence of frontal bossing in some cases. Let us look into the oral manifestations. Maxillary hypoplasia and a parrot beak appearance is very classic feature of these subjects. In some cases, facial angle is exacerbated and the patient nose is prominent pointer resembling the parrot beak. High arched palate and dental arch width is reduced, giving the crowding. Unilateral bilateral crossbite is evident with open bite and crowding. Shovel shaped maxillary incisors, cleft lip and palate are also evident. Radiographic features. Absence of the sutures. Digital marking in the skull as a result of increased intracranial pressure from early synostosis of the cranial sutures is seen. And then there is a classic feature called as beaten silver appearance. The cranial walls are thin with multiple radiolucencies appearing as depressions or scalloped appearance of a beaten silver. Other malformations would be malformation of the calvarium, flattened mandibular angle, conical teeth and partial enodontia. Moving to the diagnosis. High arched palate with mid-face deformity, proptosis is a typical feature of Crouzon syndrome. And radiographically, beaten silver appearance in the skull will give us a point diagnosis for these lesions or diseases. Moving to the management, midfacial advancement has to be carried out or done to correct the midfacial hypoplasia. Craniectomy is needed to elevate the raised intracranial pressure, and frontoorbital advancement is done to correct the ocular defect. We will look into the last defect, that is a mandibulofacial dysostosis, also called as Tucker-Collins syndrome or Franceschini syndrome. It is inherited as autosomal dominant trait. It is derived from the first and the second brachial arch. It results from the failure and incomplete migration of neural crest cells to the facial region. Let us look forward into the clinical features. There will be underdevelopment of the zygomatic bone, producing or reducing the normal prominence of the cheek which is missing, or there will be reduction in cheek prominence depending on the presence or absence of the malar bone. Another characteristic here is the coloboma. A notching line from outer third of the lower eyelids to the mouth. There is a varying degree of visual impairment also seen. There is downward inclination of the palpebral fissures giving the drooning eye appearance. Deficiency of the eyelashes also noted. There is downward inclination as I discussed, giving a drooling eye appearance. Underdeveloped or hypoplastic or malformed ears are seen. Affected infants may also have underdeveloped hypoplastic ears with blinding end or an absence of external canals, resulting in hearing impairment. Absence of the external auditory canal will result in partial or complete deafness also in some cases. Moving to the oral manifestations. Steep mandibular angle. Due to this, lower anterior teeth stand away from the upper teeth when the mouth is closed. There is micrognathia and macrostomia as an unusually large mouth, giving the fish bird fish or a bird appearance when the mouth is open. High arched palate with a cleft palate is also seen in some cases with malocclusion. Moving to the radiographic features. There is reduction in the size of the zygomatic bone. Maxillary sinus is underdeveloped or completely absent. Articular eminence is either shallow or absent. Mastoid 8 cells are reduced or absent. Jaws will show hypoplasia and teeth will be showing partial enodontia and malformation of the teeth. How do we manage them? Cosmetic surgery to improve and surgical intervention should be done to improve the osseous and ear defect. Summary in a small box of a memory of what we discussed today. Cleidocranial dysplasia. It is also called as cleidocranial dysostosis, Marie-Santon disease or craniocleidodysostosis. Classic feature is shoulder meeting in the midline, open sutures or open fontanelles with radiographic feature of Voumerian bones, underdeveloped lacrimal and zygomatic bones. Radiographically, again absence of the clavicles, multiple supernumerary teeth, pointed coronoid process, blunt angle of the mandibles will give us one classic diagnosis of cleidocranial dysplasia. Next is craniofacial dysostosis. It is also called as Cruzen's disease or a syndrome. Autosomal dominant in character. There is presence of a boat-shaped skull or brachycephalic skull. There is proptosis and strabismus. Cranial malformation giving the clover leaf appearance. And then radiographically you can see a silver beaten appearance and a blunt mandibular angle, and also there is mandibular prognathism. High arched palate are also seen with oral manifestations. How do we diagnose them? High arched palate with midface deformity, proptosis will give us a diagnosis of Cruzen's syndrome. Radiographically, we should consider the beaten silver appearance and then come to the point diagnosis. Then we have what is called as mandibulofacial dysostosis, also called as Strecker-Collins syndrome or Franchesti syndrome. The ears are malformed, which are hypoplastic or dysplastic. Eyes, downward inclination of the palpebral fissure. Coloboma presence, that is a notching from the outer third of the lower eyelids. Zygomatic bone underdeveloped. Malar bones not prominent. Oral manifestations will give you a appearance of underdeveloped mandible, crowding with the lower anteriors and upper anteriors, and high arched palate, micrognathia, macrostomia, and one classic feature is fish or a bird appearance of the mouth. Radiographically, you will see reduction in the size of the zygomatic bone, maxillary sinus underdeveloped, mastoid cells are absent or totally small in nature or reduced in nature, hypoplasia of the jaws, and partial enodontia and malformation of the teeth. Then we will come to the diagnosis of this mandibulofacial dysostosis. Thank you.